community of practice. So really, really appreciate being here, Martin.
Oh, it's my pleasure. And I've heard about your work through the virtual rapid access clinic program. I think that is run in Ontario, and I believe that they have established the communities of practice. And I wondered if it was the same one.
I think it's a different one. This one that we
Mhm.
do, it's like a Canadian TeleRehab community of practice.
Ah,
And it's like for people across Canada who are interested in TeleRehab, we have members from up north, and we have people from BC to the Maritimes. And we just meet once every 3 months to talk about interesting things related to TeleRehab and to share what each other's work and basically just get along and try to advance TeleRehab in Canada.
mm, that's great. Yeah, the one I was thinking of was pretty well limited to Ontario. So fantastic that you've got this reach.
Well,
Yes. Um, and hi, Martin, it's Michaela here too. So thank you for joining. I really appreciate it. And I just wanted to mention a couple things. So yeah, so we will record if that's okay with you.
Of course, yeah.
And yeah, we can see your slides well. We're seeing sort of the PowerPoint view. So I think once you sort of click starting the slideshow, we will be able to see the slideshow view.
yeah,
Yes,
Martin
what
tried it
are
with
you seeing
me.
me at the moment on the
Perfect.
slideshow?
Okay, perfect. So then I've got a couple slides that Meich and I will just go over before you start. So once we let people in, then if it's okay with you, I'll switch to our slides just to introduce you.
Yeah. So I'll
And
stop sharing.
exactly. And then
There we
time-wise,
go.
does it about, 20 to 30 minutes for your presentation and question answer? Does that work for you?
Yeah, perfectly. Yeah.
Okay, perfect. Well, that's great. Well, I think we actually are letting people kind of come in as they do, which is just great. So we'll welcome those who've joined. Mechi, I guess I could bring up our slides if that works. And did you want to do the intro or would you like me to? Either works for me. Oh, you're just on mute.
You can do the intro. I can do the clicking of the letting people in. And I
Okay.
see Alyssa is here. Erin is here. Hi, Erin. Great to see you again. Katarina is here. Stephanie is here. Valerie is here. Hi, everybody. Hi, Carolina. Great to talk with you again.
Hello.
Hello.
Oh, and somebody's Read AI meeting notes taker is also here.
Yeah, that could be. I wonder if that's part of our, yeah, so there we are recording. And I don't know if it's also got a bit of a meeting summary that comes with it. Could be. But we'll give
Okay.
it just, yeah, a couple more minutes.
Hi, Monica.
Yeah.
Oh.
Trainer.
Hi, Tara. Hi, Ness.
Hello.
Hi, good morning.
Oh, and we have another AI note taker. These are like the agentic AI note takers that people send to meetings when they can't attend. I know we're recording, but I think I'm just gonna let them in. Maybe some people prefer to have a written summary of the presentation, Rob. I don't, I'm too sure. So, hi, Kelly.
Hello.
We're gonna get ready in start in a few minutes. I think everybody's just kind of trickling in.
Sounds good. Thanks.
And I hope it's okay. I have a student with me today. This is Rebecca beside me. She's just going to observe this session if that's all right.
All students are welcome. Yeah, and like anybody's colleagues is welcome. Like whoever you want to show to, like, yeah, we welcome everybody.
Great, thank you.
Hi, Kenneth. Thanks for coming. We're gonna get started in a few minutes, just giving people a bit of a chance to trickle in because I know there's people who are like, they got patients and then they have to like go back to their office. So
Yeah, more are still coming in. This is great. It's so nice to see so many different members of our community.
yes, Angie and I are trying to click as fast as we can. Oh, hi, Carl. Hi, Andrea. Great to see you folks
So
again.
what it is I do that there's the letters that
Hi, Rena. Great to see you again.
Hi.
We're gonna get started in maybe just 1 or 2 minute more. We're just giving
Yeah.
people who might have to transition from like clinic or the gym back to their office at 12 a chance to get in.
Exactly. Yeah. So for some of you, it might be 1, some it's 12, 11. I know we've got people all across the country. So if we're falling in your lunch hour too, just as we always do, make sure you know that you can have a bite to eat. Well, we're a few minutes after, Meiji. What do you think? Should we get started? And then we are recording, as we said. So the recording will be shared with our community after the session. But I hope everyone is staying warm and enjoying a great start to the new year. Um, on behalf of Meiji and I, we're very excited for another TeleRehab community of practice session. And we've got, lots of members of our Toronto Rehab Working Group. You probably can see Angie is there as well, who's helping us with our tech support too. So we've got a really exciting presentation from Dr. Ferguson Pell. So I'm going to introduce him in a moment. So that will take the first part of our hour. And then in the second part, I've got a little bit of a recap planned of where we've been with our community of practice so far. And we've got time for a little bit of a facilitated discussion about where we may want to go next. So we just thought since, believe it or not, 2023 that we first started having sessions, that it might be a nice chance to just regroup and have a look at how things have been going. I'll just remind you of our Toronto Rehab TeleRehab Working Group. So you'll see some of our members that have joined today. Please remember as well that you can look at our community practice website for resources and events, and you can also join our directory that's shared so that you can also link with other like-minded people that might be doing similar work. We always love to know who's here. So if you are able to in the chat, we always love to know who's here, where you're from, and your discipline. So we can do that just while we start the presentation as well. And now it's my pleasure to introduce Dr. Martin Ferguson Pell, who's presenting on expanding telerehab with point-of-care technologies. He earned a BSc in physics from Exeter University and PhD in biomedical engineering from the University of Strathclyde. He has held academic appointments in Glasgow, New York, and London before being appointed to the Dean of the Faculty of Medicine at the University of Alberta in 2007. In 2012, he established the Rehabilitation Robotics Laboratory, where his team leads advancements in extended reality and artificial intelligence integration for healthcare simulation. He also founded Elixir in 2019, a province-wide collaboration among 11 Alberta post-secondary institutions and developer studios focused on using XR effectively in education and training, particularly where complex 3D simulations challenge traditional learning approaches. His research group also develops and deploys virtual clinical assessment tools, enhancing access to care between urban specialty clinics and rural health centers. So it's my pleasure to pass the floor now to Dr. Ferguson Pell. So those of you, I will keep an eye on the chat, but we should have a few minutes for questions after the presentation as well.
Thank you very much. Just want to make sure that I'm sharing effectively, and that should be full screen view. Is that working?
Yes, it looks great. Thank you so much.
Excellent, great. Well, thank you very much for the opportunity. It's really exciting to see a strong focus on developing a community of practice, and I'll probably demonstrate through a couple of examples as I go through my presentation why I think the community of practice approach is critical for us to be successful in improving access to care through the use of virtual care technologies and point of care technologies. So without further ado, I don't think this is a surprise to most of you, but approximately 18% of Canadians, or 6.6 million, live in rural settings. And these access challenges that they face are not really limited just to rural communities, in that so many people that we speak to who maybe live in an urban community but still have challenges getting into hospital appointments, whether they're because of mobility limitations or need for carer support or family support, or just the challenges of getting into the city and parking and finding their way to an appointment. So this is a very big issue in my mind, and the impact that not having access to care or having challenges in access to care can result in a whole series of things. And so not only the burden of travel on the patient, which obviously has implications in terms of time off from work and so on, but also results in poorer health outcomes because care is delayed, and those care delays result in more significant and more severe outcomes, which then require further treatment, and also increase the likelihood that that person will need emergency department services in order to deal with something that maybe could have been nipped in the bud much earlier on. And the system itself, our healthcare systems really have some challenges around the need to be able to address this. In other words, it's not something that we can turn a blind eye to. It's an ethical issue. It results in professional isolation of rural clinicians. We also know that that there are workforce shortages that are going to be very difficult to address through just the expectation that we can hire someone. We also see higher no-show rates. All of these things are system challenges that, to some degree, we believe virtual care can help take some pressure off. So the sort of thing we're doing at the moment is we have a number of sites around Alberta where we have put what I would describe as more enhanced virtual care systems, platforms, if you like, than the traditional Zoom call. And this is where we embed point of care technologies alongside the virtual care communication system, which we use as Zoom for Health. And we can therefore provide more complex, more advanced assessments, and therefore link people to specialists who may not be available other than to make that visit from the community to that acute care setting. We also know that we have these other issues that are occurring right across the system, the clinician shortages and burnout. We know that those factors affect rural communities even more than they do in the urban communities, and so on. We have long wait times. We're all familiar with these challenges that we have seen COVID sort of brought to a head, but they were lingering in the background for a long time. And they're also not unique to Canada in that in various ways, many different healthcare systems share similar problems. And when we look at just primary care access in Canada, 1 in 7 visits are essentially to the emergency department. And we're seeing our emergency departments absolutely crowded out and very long wait times. 8 to 16 hours is not that unusual. And yet many of those could have been handled differently and maybe handled virtually. So when we look at the statistics behind this, we can see that we've really got a crisis in that we're not meeting the needs of Canadians in terms of being able to get access to primary care. And the problems that we see in access to primary care, just in not having access to a primary care clinician, is becoming more and more of a challenge, and very challenging in rural settings. And when we look at the system pressures and where those pressures lie, you get a sense here as to what the number of wait days are for the 75th percentile across a whole series of different specializations. So this gives us an opportunity to look at where maybe we could intervene with virtual care and maybe help to take some of that pressure off. But as we'll talk about in a few minutes, that's only going to work if those assessments and those interactions that occur actually save time and resources. In that, certainly the way the healthcare system looks at it, and it's understandable, if a virtual assessment is going to take longer than an in-person assessment, it's not going to make things better in terms of wait times. It may improve access for those people able to access it, but it doesn't overcome the problem of increasing wait time. So the onus is very much on us as people developing virtual care systems to find ways of delivering virtual assessments that are as efficient and as time sensitive and as confidence building among clinicians as it would be if we were working with someone in person. This is hardly new to you. Obviously, one of the important opportunities around providing virtual care is that we have that opportunity to create communities of practice, as seen particularly by people in rural settings. So one of the problems that many people face in rural settings as clinicians is that professional isolation. A therapist, for example, in an urban clinic probably can just look across the room to someone who may be more experienced in a particular area and get help and support with their patient. If you're working on your own in a rural community delivering those services, you haven't got that access. And so the opportunity to create communities of care and relationships that enable people to connect virtually is a real positive for people in those settings. So one of the important ingredients, we think, for introducing new technologies and new solutions is to really promote a co-design approach. And the approach that we've been using has been the sort of PDSA cycle, Plan, Do, Study, Act, and also this human-centered design thinking approach that you can see in this double diamond model. So the idea behind the double diamond model is that at the very beginning of looking to try and solve a problem with a new approach, you look at really all of those things that define that problem. So rather than just immediately center on one thing, what you do is look at the community of people who are involved in the challenge that you're trying to address and engage with them and get all of the things out on the table so that we can then start to sift through those and systematically narrow them down to the specific problem that we want to work on. Now, we're not going to address all of those things in that first half of the first double diamond. We're going to pick on one that maybe is doable and impactful. And that might be the way we would classify the approach to the specific problem we're going to address. And then the second part of the double diamond is then to ideate that and say, okay, we know what the problem is. We've decided, we've narrowed it down to this very specific thing. But now what are the potential ways of addressing that? So you open the second double diamond up with again, imagine, a mass of yellow stickies on the wall that suggest ways we could go about it. And then the second diamond is narrowed down again, where we then narrow that down to a specific solution. And remember, throughout this process, all of those people that have a stake in the final implementation of the solution are involved in that process right up front at the very beginning. As an engineer, one of my tendencies is always to want to jump to the solution and imagine that somehow I know what the solution should be, and I just want to get on with it. And I can't help myself in doing that. And my colleagues who work in technology development, that is a natural tendency for us to do that. And this is a discipline that we need to have. But there's another side of the story that not only is this causing us to interact with the community of people that we're working with, but also it's bringing people in to become stakeholders in the solution. So that as we get closer and closer to starting to try it out and then ultimately try to implement it, we've already got people who become champions for it. And so the idea that you can come up with a solution, parachute it into an environment, and imagine everyone will become immediately enthusiastic about it does not bear out in our experiences in working in this area. So that's just the approach that we've been looking at. And I also want to point out, and this is very complicated discussion, we could spend an hour just talking about this, but it's also looking at how these different systems interact. So on the one side, we've got the community, the rural remote community, if you like, with all sorts of things going on in that environment, delivery systems, people in the community who support people, data that is being generated by wearable devices, information that's being collected by a variety of different providers. And on the other side, you've got the urban tertiary clinic where that patient may end up going, or there may be an interaction to say, should this patient come? The problem we have is that those two systems do not talk to each other very effectively. And so when the emergency room doctor gets a call in the urban center to say, I have a patient here with a particular crisis, and I'm not sure whether I should send them to you, the available data to that emergency room doctor to know the background of that patient is very, very limited. And one of the things that really needs to be addressed is to tighten up that information flow between those two communities, because it works equally well going back. And when the person is being discharged, going back into the community, the amount of information that is held by the informal providers of care, if you like, in that community, in addition to the formal providers, can be very limited and very scattered, and often it results in poor communication and ambiguous discussions about the approach that should be adopted. So all sorts of problems we have around communication. The opportunity to use wearables is interesting because not only do they collect interesting information that can sometimes be helpful in situations like the one I just described, but also they are patient-owned data. And so to some degree, when it comes to transmitting that information from the patient to a care provider environment, it's their decision as to what they're going to do and whether or not they're going to share it. That in some ways can break down some barriers because that decision is theirs rather than the system's decision. Obviously, data coming from the system to the patient and to the other providers in the system, that becomes more tricky unless you're in Epic or Clinic Care where you're talking just about the acute care setting. So my ideas around point of care technologies and why I think it's important. Let me just be controversial for a second and say, imagine you walk into your primary care doctor's office right now. What will you see? I think you will see on the wall a pressure cuff for measuring blood pressure and a thing to look in your ears. That's about it, and a couch, right? And nearly everything that goes on there is an assessment, a gatekeeping process, a referral, rather than a specific intervention. In fact, someone said to me recently, if I go to my primary care doc and I've got a sore throat, if it's suspected to be strep, I'm sent to a lab to have it done. If I go to my pharmacy, they do it on the spot. So what we're saying is, can we start to introduce into the primary care environment technologies so that care can be provided at the point of care? I realize that raises all sorts of questions about capacity and funding and so on. But I think we should be open to just thinking about how that could possibly be done and working towards solutions that would work given the constraints that enable delivery of care at the point of care rather than have to send patients out into the system. And we hear from patients all the time about how they are frustrated by the siloing and fragmentation of care and how they feel that there isn't good communication among all the different specializations that are maybe looking after them if they have multiple morbidities. And so there are concerns patients have. There are real challenges in trying to make the system do it because of the resource implications, but I don't think we should rule it out. And that's my particular mission, if you like, is to look at that. So this is one example of where we can use a low-cost camera. It's a 3D camera, or what we're now doing is using an iPad Pro, which enables us to make measurements of the patient and transmit those measurements from the rural community or remote environment back into a specialist clinic where maybe someone is going to be doing a more complex assessment. So this is an example of how you use that technology. It's called markerless motion capture. And what you can do is start measuring things like range of motion and balance, for example. But you can do that in a quantitative way. It gives you numbers behind this that enable you to communicate effectively. And eventually we will have normative data that will enable us to make comparisons between an individual patient and maybe other people who we would want to compare them with in terms of the severity of their loss of balance. And this is an example also of how this kind of measurement can enable us to look at things a little differently. So we're all familiar with the sit to stand test. What do? We ask someone to do sit to stands, a number of sits to stands that might be completed in a fixed amount of time. There's a lot of missing information that we could be gathering from that if we would use a measurement tool. So for example, when the person is in the sitting position, to go to the standing position, they lean forward, then they stand up, then they stand and they might sway for a little bit, and then they go back into the sitting position, and they may plop back, they may sit in a very controlled way, and then they go back to the neutral position. We can measure everything that's going on during that time and extract information from it. And this is an example of what we were able to do. So we took some of those parameters. We took 3 populations. We took a healthy adult population. We took a community dwelling senior population and a supported living senior population. And we measured the parameters within the sit to stand test. And I think what you can see is this cluster analysis is clustering people differently because of their risk, we believe, of probably falling. And what's interesting is not only that it differentiates those clusters quite clearly, but you can see the outliers. Those outliers, the people on the right-hand side in the red circles, probably are the most likely to be at risk for falling. And that gives us a really concrete way of being able to do that kind of assessment using that kind of point of care technology. Another thing we use are telepresence robots, which give the patient this sense of connection between the person who is in the urban setting and their care setting, let's say in a rural community. And also it improves their ability to hear, and it also improves their ability to use non-verbal cues as part of the conversation, which for seniors with seniors-related hearing loss can be a big factor in determining whether or not they feel engaged in the whole process. So this is the sort of technology we use. So we've got the robot there, we've got the camera, we've got a computer, we've got vestibular goggles that we use for doing vestibular assessments. All of these are being done virtually. And another area we're working on right now is being able to do remote upper extremity spasticity assessments for people who've had a stroke. And we want to identify those people with significant loss of upper extremity function as a result of their stroke, and whether or not they might be a candidate for example, Botox injections or better suited to a physical therapy program and so on. And one of the challenges with this is that the severity of the spasticity doesn't show up until some time after discharge. And so once the person has gone back to their community, they're kind of lost to the acute care setting where they were cared for originally. And then it's up to whatever happens in that remote or rural community as to whether or not anyone actually sees the opportunity to help to restore some of their function, or whether someone just says, you know what, this is just the nature of it. This is what happens when you have a stroke. And so we're looking to see whether we can improve the ability of undertaking these assessments by introducing some expertise to doing it without having to have the patient travel into a center. Another thing we're doing right now is looking at the problem of unhoused people. So in Edmonton, we have a newly emerging program called Bridge Healing, which creates residential facilities like this. They're rather like you would imagine a student dorm. And people who wish to participate in the program can use this facility. This will be their residential setting in order for them to start to make a transition back into the community. And one of the things that we found is that there are significant clinical problems that the people coming in to this program have. And one of the top of the list is wounds of various types. So what we're doing is we're using virtual care as a way of assessing people to see whether we can advise on the care of unhoused people without them having to be referred and then find their way to a clinic appointment in a big tertiary hospital where invariably they will never make it. So what we're trying to do is deliver care at the point at which this person is being contacted in the community, perhaps into this residential community or into some other support system within the community we're working with. So that's the Bridge Healing Program. And then another area where we're using these technologies is creating spatial meetings where we can use virtual reality goggles in order to help people who, for example, have had a spinal cord injury, create a community of peer support. And so we've been looking at the comparison between using spatial meetings approach to peer meetings versus Zoom. And the results have been very promising in that people really do find the immersive experience much more engaging. The conversations are much deeper through the use of this technology. There are some barriers which are associated with accessibility of the headsets due to the controllers that are used. And for people with upper extremity functional loss, they have some struggles with being able to use the controller effectively. But we did get some workarounds and we've been able to demonstrate reasonably good success with this kind of technology in our first run through. So there's lots more to talk about, but I think we're probably at time. I'm around about at 20 minutes. And so maybe what I should do is stop at this point and then invite questions.
Thanks so much, Dr. Ferguson-Pell. It's so interesting to see all the different ways that you're supporting people remotely while still using an evidence-based approach to high quality care. And I really loved even the models you showed of how you developed that. Like the double diamond model is something I'd never seen before, and we'll definitely look to try to incorporate in terms of future innovation. So thank you so much. So group, yes, we do have time for questions and comments for this part. So please just unmute yourselves and ask your questions. I've also got the chat open, so you can put any questions in the chat as well.
I have a question. So I am so interested in the RRL Viva Connect. Can you tell us more about like what availability of that technology currently is, or is it only in research settings?
Yeah, it's mainly in our research settings at the moment, because one of the things that we could have a long conversation about is making sure that we overcome the regulatory requirements that are needed to be resolved. And so, and usually that you can only do that when you've stabilized what you're doing. So you've got what you're ready to say is pretty well your final solution. And so it takes a lot of resources in order to get regulatory approval, for example. So a lot of what we do is under an ethics protocol, which gives us more flexibility because people are giving informed consent to participate in a research project. But the network of virtual care sort of capabilities that we've been using are using predominantly off-the-shelf technologies. So the teleconferencing system that we use is Zoom for Health, which meets our PIA requirements. And then what we do is we use devices that are point-of-care devices, if you like, that we can share using the shared screen capability. So in other words, if the device runs on the computer that we're using for the teleconferencing session, we can share the screen and that shows you the dashboard of that device. So, so for example, if you wanted, you could use a stethoscope and the audio of the system that you're using could be used through desktop sharing to give you audible transmission of the sounds that you want to transmit using the stethoscope. And then you can do all sorts of other things like EKGs and so on and so on. And all of those are just shared using desktop sharing. And that way you're not transmitting actual data. You're just transmitting visual images. And that's by far the simplest way to do it from what we can see.
Oh, you're just
Oh.
on mute, Meiji.
Well, thank you so much for sharing that. And I just want to clarify. So for an chatbot like RL Viva Connect, like it does, if let's say it goes through, it's all stabilized and everything, does it require Health Canada approval as a medical device?
No, I don't think so. I think that that would probably not require it. No, it would only be the devices that are directly used for decision making. In other words, the data that's being generated is the data that is used to make a clinical decision. That's where the Health Canada approval would be required, but not the
I see.
platform.
I see. Thanks. And Carolina turned your screen on. I don't know if you were thinking of asking a question or
No, I'm just enjoying. Thank you so much for sharing these amazing resources. A lot of thoughts here for the future. Thank you.
Rena, go ahead, please.
Thank you so much. This was such an interesting presentation. So much to think about and also software to look at. I had two questions that are kind of probably connected is one, how do you find like the human capacity piece? So like training individuals to use the devices and then implement it. Are you finding that clinicians would be doing that, or is that like an intermediary? Because you are reaching rural settings. So ideally you're actually using maybe an intermediary to set things up. If there's any tech concerns, and then the provider is sort of providing the interaction and assessment as an adjunct to whoever else is a part of the assessment. And then the second branch was just if you ever encounter any connectivity issues with the internet, just because again, remote areas, and then if there's any like solves around that, it's just such an interesting way to optimize everyone's potential. So I'd love to hear your thoughts.
Yeah, so those are great questions because the first one, we've learned, I think, some lessons, and I still don't think we have solved it. And that is, first of all, we do provide training, and remember, we've got sort of two people involved. We've got the clinician in the urban setting who, I'm just going to call a specialist, but they don't have to be a specialist, but it's someone who provides that kind of leadership, if you like, in terms of the assessment. And they're usually familiar with how the system operates. So they're not brand new to doing it. In the remote setting, that is not necessarily the case. And so you can have quite a lot of turnover in the remote setting. And what's needed is a certain amount of guidance in terms of how to set it up. So we put a fair amount of effort into making sure that they have basic training on how to switch the computer on, how to go to the application and get it started. We're hoping that the fact that we're using Zoom means that people are more familiar these days with using and operating Zoom. And so these things are a little bit more familiar than a brand new, completely different platform. So those are some strategies we use, but what we found is that still doesn't do it. And so what we do is for a significant amount of time, we actually come in as part of my team as support. So it's rather like a remote support. And most of the time, it's a problem that's very easily solved. It's a password problem, or it's my mouse isn't working, and things like that, that we can talk through and keep things moving. And so we found that availability of providing technical support is really important in the early stages, and early stages could be up to 6 months just to make sure everything goes smoothly. The second question, which was to do with the issues around bandwidth and so on, our experience is this, that because of the implementation of Connect Care right across Alberta, we found that the quality of bandwidth to the walls of the building is pretty good, and that the hardwired Ethernet type connections within the building are generally speaking excellent. The problem arises around wireless. And the reason that it's a problem is because they have been lean in inputting wireless routers and repeaters. So it's not a problem in terms of a massive investment that's needed to solve it for many communities, other than indigenous communities and on reserves. And we found that that's a different story. And it's very complex in terms of which reserves have got good bandwidth and which ones have virtually no service whatsoever. And this is just one of those really complex issues around resources, who's paying, who's responsible, and who is aligned with who, if you like, within that community. So I would say that providing adequate support for Indigenous communities is a case-by-case process of trying to solve the problems. But in traditional health centers in rural communities, the problem is internal and it's fairly cheap to sort out.
Thank you so much. Okay, let's take Kenneth's question and then we'll move on to the second part of our session after that.
Hi there. Thanks for the question. I got a big interest in the telepresence robotics, and I presented last year in health services about like what I thought potential therapeutic uses of them within some of our rural settings. I made a proposal, but it was declined last year, and I was just wondering, is there a growing push for it, or do you see them picking up a lot? I'm on the fence of whether or not to try again this year.
Yeah. So a couple of things. The double robot, which is the one that has probably been most widely used, is a low cost robot. They've gone bust, and so we're sort of saddled with a number of these robots that are limping along, and we're trying our best to keep them alive. There's another robot that is in the same price bracket, so we're talking about $6,000 to $8,000, and it's called Temi. And it's not as clever as the double robot, and it doesn't sort of balance itself, but it's more robust. And we have one Temi in our lab, and I think two Temis out in the field. We've had very little trouble with them. So in terms of choosing a product, if you're in that price bracket, then I would look at Temi as being probably the most promising direction to go in. Thing I think you have to decide is there's a cheaper solution, which is to use smart glasses. So if what you're wanting to do is to transmit what you're seeing to someone in another location, you might be able to do that successfully, and wanting to do this with flexibility, so you can move closer to the patient, look closely at a part of the patient that you're wanting to give information about. Smart glasses might do that, but it's not really what we mean by telepresence. In that telepresence is really about the patient feeling that the person in the urban setting is in the room with them. And so it doesn't achieve that. So I think if I were putting a proposal in, I would be really emphasizing the patient experience. So we can give you some feedback on that directly if you just contact me. The other place is Stacy Lobo in Saskatchewan. They use these robotic devices in rural communities quite extensively. And Stacy can give you lots of good stories about the effectiveness of using this technology in the settings she's responsible for, which are very rural communities, very remote. Many of them are indigenous, and the response has been very, very positive in Stacy's application area.
Okay, sounds good. I'll connect after.
Yep.
Yeah, thanks so much, Dr. Ferguson-Pell. And I do think Stacy may be part of our community as well. So yeah, if you need any help linking, Kenneth, if you don't know, happy to help as well. Dr. Ferguson-Pell, that was amazing. Thank you so much. So I think we all learned a lot, and I think this is kind of a nice transition to the next part of our community where you've showed us so much innovative things that we can think about. And part of what we wanted to do today is just have a look at where we've been so far with our community, and also just have a little bit of a chance to weigh in on sort of future things we want to learn together, and also where we want to kind of take our work next. So H and I just have a few more sort of slides to guide our discussion.
Okay, so I will
And-
jump off at this point, if that's okay with you.
Yes, you most certainly can. Yeah, well, thank you so much again, and really appreciate it.
My pleasure. Thank you. Best of luck. Bye for now.
Okay, so let me share my screen once again. And okay, let's see if I can bring this up. So just switch this. Okay. So this was actually fun to make because it gave me a chance to also have a look at how this community of practice started just as an idea from Meiji and the working group. And we didn't know, like, when you start something, what's going to happen? Is anyone going to want to join? But we felt there would probably be a need. And based on all of the exciting work that we've seen so many of you do, we had a hunch that there could be an interest to come together and form a Canadian community practice. And I'm so glad that we did. And it's such a collaborative, fun group that we've all put together. And I think as I've seen, I was looking through who's here today and just thinking of how some of you have been presenting and interacting, and it's just wonderful. So believe it or not, we are 230 members and growing. So I think one of you brought a student today. Thank you so much. Thanks to our student. Please, if you want to join us, you are most welcome. So please continue to spread the word through our website. And as we mentioned, through our directory. It's so nice to hear because a lot of us are sort of in this shared space of similar work. So sort of hearing names that are familiar and thinking of ways that we can maybe just link up and support each other's work. So that's part of why we have this directory where we can all kind of interact. So AI helped me to make some analysis of who's here. So it's not perfect because it couldn't kind of pull from our survey who everyone is, but we could see that we have a robust administrative and leadership group, which I think is really cool because when we're thinking about innovative technologies and changes that we want to make in the telerehab space, I think that often having administration and leadership buy-in is so critical. So I really love to see that. And then for sure, lots of different allied health disciplines, physio, OT, and SLP especially, but also nursing, psychology, educators, physicians, social workers, researchers, kinesiologists, and there could be other smaller groups as well. But kind of nice to just see some of who's here and has joined our community. And then in terms of our sort of geographical spread, so we've got, we span most of the provinces and territories. We were missing, we didn't have anyone from Nunavut, PEI, and I think it was Northwest Territories as far as could be analyzed from, but also the data wasn't perfect. So it could be there was some that we just weren't able to capture. But otherwise, we kind of span the rest of the provinces and territories. So I think that's really nice to see that, because we want our community to represent sort of the different populations we serve and our large, beautiful country that we have. So I couldn't believe it. Like, yes, the time flies, I think, when you're having fun and enjoying what you do, because our first session was actually October 2023. And we've aimed to try to have 3 or 4 sessions a year with a combination of presentations as well as times where we could interact and discuss. Like every once in a while, we'll try to have a session like this where we can just have more of an open forum. So we've had topics anywhere from cognitive assessment, APTA guidelines, functional movement disorders, rehab in conflict zones, safety of telerehab. We've also had some great kind of combination presentations where we've learned about different we learned about telerehab spot. We also had language and communication. We've done kind of different innovative technologies, ergocentric video, cardiovascular rehab applications, equitable telerehab. We had our showcase as our last session before this one, where we learned about kind of 3 different innovative telerehab programs. We've got our session today, and then we plan to meet next in April to go over some gray literature search on devices presentation. We're working on one more piece for that session as well. So lots of cool stuff. And so we wanted to just sort of hear from you now. So we have a few questions for discussion. So you can go to slido.com and enter this number 338-7553, or you can scan the QR code. Hopefully you'll be able to see it because the first question is live, which is asking what have been your key learnings and takeaway from the community of practice so far. So let me see if I can present and maybe switch this over. What I don't know is if I switch, like, are you now seeing our Slido? Oh yeah. Oh wow. I honestly, I did not think that was going to work. Yeah, so hopefully you can see this. So this isn't, it should be anonymous when you answer. I hope. But it would, sometimes I find it's nice when we're learning to just be able to sort of have a moment for reflection because, you know, you're investing a lot of time and effort into coming and attending and really being engaged participants. And so I think we just wanted to sort of think about how that's been going and what we've been able to take away. Yeah, so lots of people, it looks like, are typing, weighing in. So yeah, the number of people who are interested in TeleRehab, what other regions are doing, and new technologies. Yeah, the technologies we saw today, I was just amazed. Yeah, variety of technologies, research innovation, depth and breadth of our community. We're not alone. Creative ways healthcare providers are providing service, ways to implement TeleRehab, diversity of practice, yeah, creativity. Yeah, so there's some kind of nice themes that are emerging. I completely agree with all of you, and it is really heartwarming because I think this is what we were sort of hoping we would be able to do as a group. And yeah, validating struggles too. I think that's right. Like you're not alone in your work, and you're also not alone in the challenges. But different regions, it's what I'm hearing is do have different pressures and challenges. So I think continuing to find ways to hear about those and be able to kind of try to problem solve together. Let's give us a little, I see people are still typing, so we'll give a little bit more time. Yeah, practice in our settings of care. I'll see if there's a way after too. I think Slido usually sends me little interactivity reports. I'll see if there's a way, if you're interested, to be able to kind of share the results that everyone was weighing in on. Okay, so I'll let people kind of finish their thoughts, but I might just switch this back. Actually, I'll leave. I wonder if yeah, lack of connectivity in Indigenous communities. Work is still falling in primary research. Yes. So let me just stop this poll now. And then let me see if I can go to our next one. Because we next wanted to know which topics you'd like to see next in our community of practice. And by the way, if anyone has a topic that they would like to present, like now that you've seen a bunch of different sessions and you may have something cool that you'd be open to sharing with the group, or even sometimes I find like doing a little recap. We could have, sometimes in other groups I've had just a few people present on some of the things they're doing and talk through, even informally, what's gone well, like what's been the process and where the points of tension struggle have been. And I just find it's amazing then being able to problem solve as a group and how connections can form. So whether you want something that's a little bit more informal, just hearing about what people are up to, or formal didactic topics, we welcome all, because we do, we've got sort of time now. We do want to start planning sort of where we take the work next. So thank you so much for the positive feedback. Successful funding models people have used to incorporate technologies in practice. Okay, yeah, thank you. I think that sounds like a good idea for sure. I see lots of people typing, or yeah, like if you have any thoughts about sort of format and yeah, if anyone at any point is interested in presenting something, you can email Meiji and I, or if it's easier, Becky Rebecca Leslie, who's here, has she's always been sending stuff. So you can always send, like she sends our invites and the slides and recordings. So you can always contact her as well. So yeah, presentation from administrative leaders on how they advance TeleRehab in their regions. Get technologies for remote communities, patient and client experience. That's a really good idea. Yeah, because I do feel like one thing we could look for is how to better maybe integrate the patient client perspective. Historical use.
Oh, she tested it. Okay.
Yeah. Yeah, I know that our group, some of our groups from northern communities have potentially expressed some interest in talking a little bit about historical use. Some of our community has expertise dating back 30 years. And so I know that that's something that we've definitely thought about as well. Okay, yeah. So privacy issues and how to get around that. Education for students. I think that's would be really great as well. Like how to kind of engage with our learners, how to prepare maybe those who are newer to practice, because we know that it is a new skill like anything else. And then we've realized that there's a need for like very dedicated learning and training to start, and then to have this continuous support as well. Okay, I'm just gonna let this run for another 30 seconds. Yeah, person with lived experience to present, yeah, kind of about their experiences. I actually, yeah, would love to see if we could put something like that together. And so as we're reading this to community, if anything comes to mind that you're interested in helping with, or maybe you have a person with lived experience that you feel like would be really great, please do, yeah, write into us, Becky, Mechi, or I, because we could help with kind of setting it up. But anyone that you think might be willing to speak with us, I think that would be really great. I will brainstorm too. Okay, thank you so much. So let me just end this one, and then we'll just go back here. So this is kind of an open-ended question, because we like that. We don't want to be so restrictive. So we just wanted to take a few minutes for any other thoughts on where else we should take this community of practice. So you've seen you've sort of seen our format every few months. You've seen the kind of topics, open forums, shared Google Doc. We've got our website. We've got a resource page, but we could try to build that more. That's something that could be interesting, because we don't have too many resources on there now. We do, anyone who wants to have their work highlighted, that's always an option, kind of either there, or I do have a little announcement actually from someone in our community at the end of today. So, announcements to highlight work, but any other ideas that anyone has of where we should take this community of practice? Yeah, very interesting. Yeah, presentations in rehab schools across Canada. Like, I love that idea. Maybe thinking about like TeleRehab specific, or maybe trying to get people more aware of what the different options could be. Thank you. Yeah, I see more people typing. Yeah, collaborating on projects. Yeah, so I think as we kind of have projects and there's an opportunity, I think that was always one of our visions as well, that we still want to try to find ways to continue to collaborate with one another. Yeah, community of practice forums. Like I wonder, yeah, like discussion groups or forums. That's an interesting thought to explore too. And kind of continue to connect with professionals in the group. No limitation to number of participants. We want to grow. So yeah, please continue to spread the word, and yeah, you could have your whole team involved. Thank you so much for your positive feedback. Yeah, podcast. I know, truthfully, I never listened to a podcast till this year when I moved, and now I have a little bit of not a long commute, but a little commute. So it's true, whether there's anyone who'd be interested in even whether doing their own or just trying to make, if anyone finds good podcasts, like whether we want to have a little resource library of like continuous learning for us, like if someone found a podcast they liked, a way they could more easily share it. Okay, so thank you so much all. So we'll leave this for another 30 seconds. I'm just going to give Meiji the floor for a sec because she's got to step off. Anything, Meiji, you want to add before you go?
No, it's so great to see everybody's thoughts, and Michaela and I will definitely take the feedback that we got today, and we'll come back to the group with next steps. And yeah, it's really great ideas. Thank you so much. Sorry, I just have
Thank
to
you.
go to a care conference. I apologize.
Thanks so much, Meiji. And yeah, this is a good point too. Would we want to come together within respective professions? Like what I'm now, correct me if I'm misinterpreting, but it sounds like maybe wondering about a community even within the community of practice, like, SLPs or OTs or PTs. I feel like that could also be interesting, right? Because we know context really matters. And I think there's some stuff that applies to all, and then there's some things that probably you would have that sort of shared knowledge and expertise that would sort of match very well to exactly what your discipline is. Yeah.
Michaela, that was me. And it was very selfish because I just have to say, and it's a shout out to Kaylee and other from our a recent pan-Canadian group where we got together, and there was 3 physios in my group, and they were all from across Canada, and I had such a great time. And so I was just sort of picking up on some of that energy, also acknowledging that seems to be a cluster of OTs and PTs and assistants within our group.
Yeah. Angie, I love it. Yeah. So I think I'll stop sharing now. Thank you so much all for participating. So I will, compile all this, have a look at it in more detail. Yeah, don't hesitate to write in anything else that you that kind of comes to mind. But we've got a couple minutes too. Did anyone want to sort of add anything or have any feedback that they want to share? There's no pressure to share, but we do have a couple minutes if anyone wanted to share anything. Okay, thank you. Yeah, Caroline needs to leave. Yeah, anyone who has to leave as well, thank you so much for joining. Please feel free. Let me just bring this back. Because I just have one other thing, if not, I could share my screen one more time. And I've shared my other screen, no problem. So, okay, yeah, I think you can hopefully see the screen that's not in presenter view. I've lost you all, but I think you can hopefully see this. That Ruth Barclay and Jennifer O'Neill, who are members of our community, had just wanted to make you all aware that they're doing a study on Canadian research priorities for telerehabilitation within rehab centers. And so what they're trying to do here is identify telerehab research priorities in Canada with a focus on equitable access to telerehab services delivered from rehab centers for people with neurological conditions and chronic illnesses. So it does apply really nicely to a lot of the work from those in our community of practice. And I think to what we've been talking about of trying to kind of identify priorities and what we really are trying to do next, especially when it comes to equity. So if you're interested, the link is here, or there's the QR code. There's a deadline of 6 weeks, and I can connect with Becky too, so that this info can also come to you in the kind of post-session information. But if you've got time, I feel like this is really valuable. I'm definitely going to make time to do this. And so I just wanted to make sure everyone knew about this as well. Otherwise, I probably prematurely stopped sharing because we always have a little bit of an evaluation as well from so I think you can hopefully now see my screen again. So if you don't mind, and Becky, if you're still there, if you could post this, the evaluation link in the chat, that would be great. But you can scan the QR code just so that we can get some feedback on the session as well, like we always like to do. But if there's no other kind of thoughts, then thoughts or feedback, please feel free to go. And thank you all so much for attending. And I see some really nice feedback. Yes, the session was recorded. Yeah. And thanks so much to Linda for your positive feedback as well. I'll stop sharing. So thanks so much, everyone. And just in case, I'll just put this in the chat too. There we go. Just so it's there too. And thanks so much to Angie for all everything and for supporting with all of our tech today as well.
Do you have 2 minutes to stay on the line with me?
Oh yeah, I'm muted. Yeah, I sure do. We'll just, maybe I can stop the recording, or maybe it's still, hang on. It's still recording. I wonder, Angie, if I just call you separately? Or, oh no.
I just stopped it.